Hey everybody, it's the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got Caleb Ferroni and Ray Pace and Dr. John Hill with us yet again. Special 5-part series for all of 24. So what we're doing is we're doing a ongoing sub-series on EMS airway management. All right, so stay tuned for this installment of EMS Airways. So anyway, this comes in assembled kit just like this. The syringe back here is once you have made your entry into the cricothyroid membrane, you're going to stop at this red stopper at the level of the skin. This allows you to aspirate and make sure that you actually got air. Okay, I suspect you'll see a little bubble or splash of blood or something in there. I wouldn't be upset about that if the whole syringe was filling up with blood.
If it's auto-filling with blood, we have a big issue.
Specifically if it's auto-filling, right?
Yes.
If you introduce it and it fills itself with blood,
You're in the wrong space.
yes. You've got a lengthy review process ahead of you, but yeah, you would just pull back on that, make sure you're just aspirating air, at which point we can lose this red stopper. You would tilt this back, aim it towards their feet, and just, again, slide that off. Same mental model as an IV catheter, but with far more expected force because it's a plastic wedge that you're driving between the cricothyroid and the thyroid membrane, or cartilage. So I'm just going to do, again, upside down here and a less.
And I teach us the same. I teach us very similar when we're talking about air return. You want to have, when you're doing it, you want to have what I call is free air return, so it comes back really easily. If you're tugging on it,
yeah,
and you create a suction and it goes right back down, you're in the wrong spot. Either too deep, or not deep enough.
Or not deep enough, right?
It depends on your patient, obviously.
Or in the case of a foreign body, you may be against it.
At that point, it would be that foreign body has already passed through the glottic opening,
Correct.
and it's at that point probably just north of the carina, right?
Mm-hmm.
And that's a really
It's
a bad situation.
It is.
All the way around.
I guess from an anatomy standpoint, that's something that we should note is the cricothyroid membrane is just below the vocal cords, right? If you were to look up, you would see the vocal cords right there. You're just below the vocal cords. You have a very short distance to get to that carina. Mm-hmm. So when we get all the way through doing a surgical cric in the way that I preferentially teach it, when we talk about scalpel, a bougie, and ET tube, you have a high likelihood to right main send these patients because you just don't have that. There's just not that much depth there.
The one of the common things I found with novice users of this is they want to grab it down here, and when you do that, I'm just going to demonstrate it on this guy's chest here. So this catheter,
It'll push
it's
out.
fixed. That needle will push out, right? So they like to grab it down here, like choke up on your bat, like from T-ball, right? When you push down, well, now you're just trying to run a blunt plastic cannula into wherever you're trying to introduce this. I have found, to keep myself honest when I do this, I'm not saying you have to do this, but I grab it like this. I'm holding the main barrel of this syringe back here. This is what I'm going to push with, but I grab that ear just so that thing that
So the
catheter
doesn't slide
doesn't
down.
walk down, right? You don't have to do that.
No, it's a good.
If you push hard enough, the place that this is going to come apart is this middle connection here where it's threaded to the metal, right? Again, I like that because it kind of splints that all together, just personal preference, food for thought, right? So again, I'm going to identify my cricothyroid membrane, and of course we'd ideally have neck hyperflexed, exposed as much of this as possible.
Mm-hmm.
We've at a minimum cleaned this with an alcohol pack preferentially betadine. I like to package betadine preps with ours. You guys splash them with a bunch of betadine in the hospital, whatever you've got available there. So we're going to introduce this, I'm kind of doing this off arm here. We're going to introduce that nearly straight down. We're going to stop when it gets to our red stopper there. I'm going to reposition, make sure that I can freely pull air, and like Dr. Hill said, we want to make sure there's no vacuum there, like I haven't split layers of skin and I'm made a false passage there, at which point that safety that which keeps us from perfing the back of the trachea, that safety can come off. We're going to tilt this down. This is where it's going to take some force to advance this, and then we're going to advance that down. And again, I'm advancing the catheter down. I'm holding the barrel of the syringe and the trocar as stable as possible, right? You don't want to push all of this forward together, because that's what's going to rip, tear, find the back of your trachea and create a really bad day. Now, once that's in, you can put a BVM straight on this. All right, you can bag straight on that if that's your preference. There is also comes this nice little flexible tube. This is, I think it's optional, but I like the concept because
it's optional, but it works so much better.
I think it's a really good idea, because you can basically do this, right? Once I've got this all secured, now I can just lay that BVM there, ventilate the patient without much pull or resistance on that.
Yeah, because you don't want to pull it out.
Nope.
I know you need to use your securing device, and that's what you're
Yep.
going to do next,
Yep.
but that's what that flexible tube really allows you to do, is not have to hold it so perfectly, because if you hit a bump, if the patient moves, if you're
wanna
jostling,
lose it, yeah.
you do not want to lose what
This
you
will
just
move
inserted.
quite a bit.
Yep.
Yeah, that gives you some latitude.
And then after we've jammed that gigantic piece of plastic in their neck, their comfort is of the utmost importance to us. So we've got this nice padded neck strap here that just simply velcros around here. This is, honestly, I like this. This is actually very convenient for our needs, that it comes on there. It's very easy to secure. I actually enjoy that how they did that. So that would be example of a quick, or of a Roush QuickTrach, but some sort of cricothyrotomy kit. Others, I think, are a little more complicated, where you have to put various size introducers and dilators in there. Some are kind of a hybrid surgical slash trocar based. So again, it really comes down to what your medical director's preference is. What
have you been trained on?
What have you been trained on? What do you have? What's your organization going to buy?
And what are you competent with?
Yep. So, any other thoughts on QuickTrach or cricothyrotomy kits before we?
The only thing that I would say with the QuickTrachs, you did 100% correct. You might, depending upon the habitus of the patient, this may not be deep enough. You might pull and get that vacuum.
And need to pull.
You might need to pull the stopper out to advance a little bit more until you get that pull back, and then you can do your advancing.
Just depends on the size of
Just
their
depends on
anatomy
the-
and how
very-
large the
very-
patient's stature is
absolutely.
and stuff.
Very good point. And of course, that takes us on to the surgical airway.
This is my preferred way for lots of reasons. One, not everyone's going to have a QuickTrach, right? Two, this is going to work on all of your patients, right? The caveat to the QuickTrach is it could be that they're too big, right? So knowing how to do a good surgical airway with a bougie and a 6OT tube and a knife, that's all you need, and you can get any airway. Obviously with asterisks you can't, but you can get any airway with this. You can get all any airway you can get with this. You have to understand your anatomy, and to the point that we said earlier, when you're doing this procedure, you're going to want to make a larger incision than you think you need to make. Again, the way I teach this is you're going to identify your prominence. You're going to identify that cricothyroid membrane, and your incision is going to be from the prominence past that and down.
Yep.
You're going to want enough room to work, because you're likely going to put a finger, a knife, plus a 6OET tube. And I don't even have large hands. I have normal sized hands. Room guns out really quickly when you're putting your fingers into surgically made holes. So I teach this this way. You want to be, I'm right hand dominant, so your left hand is going to be your non-dominant hand. It's going to go underneath the patient's chin, and you're going to flex them up if you can. Obviously, if we're worried about C-spine, we're going to have someone maintaining C-spine. You're going to try to move the neck as little as possible, but also understand if they can't ventilate, they're not going to survive. So hand underneath the chin, your non-dominant hand's going to hold them in extension and then stabilize the cricoid membrane. You're going to identify your prominence on this guy. It's here. And because he makes it nice and easy, because we've got skin here, we're going to go through nearly all of this as incision. So I take my needle. You're going to make 2 incisions. The very first one's is you're going to make the number 1. It's a vertical incision. You're going to start at that prominence, and you just want to cut through the skin. You don't need to go very deep. You're just going to cut through the skin. And in normal circumstances, this is probably what's going to happen. You're not going to go all the way through, and that's okay. Do we have hemostats?
I don't think we've got a set here.
That's fine.
You're gonna do scalpel finger bougie today.
Yeah.
I was looking for things.
Oh.
So I've made
just to excise open.
yeah, I've made my normal incision, and I can stick my finger in there and open it up. And you know what? I can only get my finger into that. I might want more room, and if that's what you need to do, or you need to do a surgical exploration a little bit more, that's fine. It's best if you can then take your knife, instead of cutting down towards, the safer way to operate this knife is actually inside the wound and cutting up. So that way, if you slip, you're going to slip up into the air and not down into the structures. Understand that there's nothing really midline, and I'm taking my time doing this. If I was doing this in real life, I would be much quicker. There's nothing.
And skin behaves far differently than this piece of plastic.
Yeah. I am going slower. I've now got my space, and I can look and I can see here. We don't have a cricothyrotomy membrane here. We just have that big giant opening we had before. There should be, there will be a ligament that goes across here. That what I would then do is I then make my second incision, which is a cut across. It's going to go into the cricothyrotomy membrane, and I'm going to saw across until I hit resistance. That resistance is the side of the cartilage. Leave my knife in place, turn around, cut over to the other side. So now I have an incision in my membrane. With this knife, what I would then do, you can kind of open it up, but I jam my knife in there, and I jam it in horizontally. This is going to be saving my spot. Understand that this is a very small space, kind of more like this, that if I was going to this space, I can't fit my knife in vertically. I have to go in horizontally to the space. This is way more what the real space looks like. Correct. It's even smaller. And then what I'm going to do is I'm going to take my knife as a pry bar, essentially, and make this vertical to pry open that space. So in horizontally, turn vertically. That's going to make my space. Now I'm going to take my bougie. Pull that off. I take the coude tip, which is that curved end, and that's going to go in first, and it's going to aim down towards the lungs. So it's going to go in, and I'm going to advance that in, and it's not going to go in very far. I'm already meeting resistance there. Remember, because our carina is right there.
Yep.
Once I've got the
there's my,
yeah,
it's right there. Yep.
Once I've got my bougie in there, this knife can come out, and then it's a simple procedure of sliding this over. And all you want to do again is you're going to make sure that just the balloons disappear inside the patient. That's all it needs to be in. Once you're in, you're going to stabilize, pull out. You're going to inflate your balloon just like normal. That's it. You can tape this in. You can put them in a C-collar. Have the C-collar to stabilize. It's going to look funny with it hanging out that far. That's totally okay. I do not recommend cutting this because the last thing you want to do is cut this balloon and lose your seal.
The way it depends on the construction of the tube, but that channel continues up here. Right?
Yes.
If you cut it up here, even though you've not done anything to this line, they can leave. Don't be a hero. Just leave it. Right.
It gives you more latitude too once you're bagging them, just like the QuickTrach does.
Yep.
So a couple.
What I also teach patients is it looks funny sticking out, but if you take this and you were to line it up anatomically, I'm actually pretty deep on this one. I'm about 21 at the teeth.
All right, so a couple little micro skills that you did, but I
didn't verbalize.
That you didn't verbalize, which is fine because it's been a habit, which is good. So here, grab your knife again, and I want to point out.
Here, do you want to do an incision?
No, I don't want to do an incision. I want you to grab your knife like you were making that incision again. And what you instinctively did was you put this hand on the patient's chest, right?
Yep.
So you weren't trying to make this free air cut, and that is a very important thing, right? You're going to be adrenalized, right? I mean, I've said this before. You guys have laughed at me, but when I get over adrenalized, my left hand shakes, right? And that's my thing to know for me to sit back, take 3 deep breaths, get back in the zone, and then go back to work, right? As I get twitchy, and just on my left hand. But that doesn't matter. Again, you preface this whole thing. That was like the most terrifying event of your life. Doesn't matter if you've done it 100 times. It's still a very uncommon procedure, and all eyes are going to be on you. It's that little extra thing of getting your dominant hand anchored and then just doing all with your fingers is I believe
just
super
think about
important.
the first time you ever started an IV on somebody. Kind of like this.
Right.
And we're not doing this every day. So.
And when it came out of the patient, it looked exactly like that. It was a Z-fold, right? And then,
but imagine this to your point, and yes, that is totally instinctually that I did that because I've been in medicine for a few years. But imagine you're doing this in the back of a moving vehicle that's going like this.
Correct.
How are you going to stabilize somebody?
Correct.
You're going to stabilize by anchoring yourself on the patient.
On the patient.
If the patient moves, you move, but in relation to the patient, you're not.
You're not, yeah.
But I bet if I watched you put a central line in or something, you do nearly the same.
When I teach the same way. I'm gonna be on the side of the face, and I'm anchoring my hand on there as I'm holding.
Correct.
Yes, you're correct.
Yeah. So, and your point about this being, you're going to have to make space here, right?
Yes.
Your technique was to use the butt of the the scalpel. There are things called tracheal hooks, which is literally just to go in there, grab and pull out.
It's a really long fish hook.
And then if your own anatomy fits, the other method is scalpel, finger, bluntly dissect, grab. You're going to be grabbing with the kind of the tip and kind of pulling back. That's your tracheal hook. If you've got big sausage fingers, it's probably not going to work all that well. But if you can, scalpel, finger, bougie, and then you're going to use basically the back of your coudes on that end. You're going to use the back of your finger there as to make the space to pass the bougie, right?
Yeah.
So,
couple
different ways.
I can tell you've been trained years ago, because right now the current thing is we don't stick digits into patients, right?
Yeah.
Whether that's finger thoracotomies or whatnot. Ideally, not less than ideal to put your finger inside of a patient.
It'd be really odd, but just the same as if we're doing this as an intubation, and if I was using it here, and this was to be buried and not stop where it was at the carina, you're probably in the esophagus.
Or you're not even in the trachea.
Or you're not even in the
You've made a
trachea.
false passage.
This is where it's really easy to make a false passage and make sure you're in the right
And
space.
you may see it follow the skin.
Yeah.
So you have to be careful. But yeah, if this does not stop at the angle of Louis or at the carina, you're probably not in the right spot. And that's the same as if you're using it this way.
Mm-hmm.
And people talk about hearing or feeling the cricoid rings and feeling the coude click is what they call it. You'd probably still feel a few here, but
you're probably not going to feel it when you're doing it with
I've
this.
never felt it intubating of it, but I'm sure it's there.
Do better.
Try harder, Ferroni.
I just know I'm in.
I guess the other thing that we haven't mentioned is some sort of facial protection, right? You should be wearing
definitely eye protection,
eye pro on this case.
And I would.
This is though.
This is 2024 when we're talking about this. We're in the post-COVID era.
Yep.
But I know that paramedics don't like to wear masks. Every time I'm in a patient's room, I am masked. I just don't care anymore. I don't want to get sick, so I just wear a mask anytime I'm in inpatient care. I would recommend the same thing for you. If you're doing patient care, you're right in the back, you should be masked. And that's to not only protect your patient, but protect you and then protect your family that you're going home to. So I always have a mask on, and all I would do would be eye protection, and I'm good to go for most things.
And again, we talked a little bit about setup of your kit and stuff like that. I strongly believe that you should have a face mask with an eye shield in your Airway kit, right?
Yep.
That again shouldn't be in another spot, right?
Have you been vomited on while intubating?
Recently, no, thankfully.
The other thing though is if they are trying to breathe when you're cutting, you're going to get aerosolized blood.
Yes.
So you need to be careful that it's
a mist.
Yeah.
Right. It's a mist. Especially if they have an upper airway obstruction and they've retained some pressure in
Yeah.
there.
If they're not dead, you're going to get a mist.
Yeah, and like you said,
And you're going to
having
get bubbles.
personal protective equipment is going to be crucial here.
And when I do this, I would recommend that your non-dominant hand's probably going to have a 4x4 in it, or have whoever your partner is with a 4x4, just kind of making sure you have a clear field to work in. That would be beneficial. But everyone's going to bleed. Dead or alive, they're going to bleed.
All right. Anything else on any of the surgical airway interventions? We've hit the 3 kind of techniques that are, I say, most common.
The only other thing I would say is, and I wish maybe that's something we should do in the future. And when I teach this too, I wish I had a giant person to teach. I wish I had a 600-kilo mannequin to teach this with, to teach properly surgically dissecting down to these structures. Your knife should only be used to cut through 2 structures. That is the skin, and then the cricothyroid membrane. That is
Ligament,
it. Anything soft in between, and if we're talking about big fluffy people that are 600 pounds and don't move and have a huge and or no neck, when you're trying to dissect through that fat, you don't want to do sharp dissection. You don't want to do it with your knife. You're going to use blunt dissection. So use the back of your knife, use your hemostats, whatever you have, to just kind of push things away. This will easily go down through all the fat. It'll push through muscle. It'll push aside vessels. It'll push aside nerves. If you've had the pleasure of being in a cadaver class and having to dissect somebody, you'd realize that you rub the fat cells will pop and kind of melt away. All the structures in the body, whether it's arteries, are very hardy. Even veins and nerves, they're very hardy. If you just push them out of the way, they're not going to split open. You can cut them very easily, but the structures that need to be hard are hardened. They're just not going to rip. So when you open up that space, and if it's a big guy or gal and you've got a lot of dissection to do, make that incision very big, just so you can get your fingers and instruments down there and then see down to the bottom of the hole where you need to work. And
Your first cut big. I wouldn't do the second cut big.
No, your second cut's only going to be through that cricothyroid membrane, so it's going to be the membrane that covers this area. And it should be whitish, grayish in color.
Right.
And again, if you're going to fail low.
Yep.
Let me see.
Don't fail high.
And just to show that technique without the overlying skin, right? So, you cut down this way, excise that open, identify the membrane, and then you cut across until you stopped.
Yep.
Spun your knife around, cut across until you stopped, right?
Yes. And that's not an incision through the skin. It's just an incision through that cricothyroid
through the membrane that would be covering this,
Yep.
right? And then, like you were demonstrating, and then you use the butt of your knife to make some space. I was showing that. We talked about a tracheal hook, but you're going to have to make space.
Hemostats, whatever you got to stick in that hole.
Make the hole better.
Just because, and this happened to me now with a cric recently, but a chest tube, I lost my path. You don't want to be searching for your lost path while you're trying to do this time critical procedure.